pain or what have you. So we want to look at ways to increase our patient's comfort. Altered body image is going to be something we have to face either as a result of the treatments or a result of us removing some type of a growth from that patient's body. There may be an alteration in that body image. Nutrition is major with this group. We need to continue to try to maintain their weights at a time that they're not going to really be inclined to eat. Food's not going to taste good. They're going to have problems with nausea and vomiting. So we're going to have to look at that. Chemotherapy brings about its own host of problems, and we'll talk about those in more detail as well. We also need to evaluate the patient's response to medications. We're going to be monitoring that cancerous growth and looking to see if it reduces in size or if it stays the same. Another issue for our cancer patient is respite for caregivers. So if you've got a spouse that is providing constant care, at some point as the nurse we need to make sure those patients are taking care of themselves. And some of the areas that we notice caregivers having problems is as they are stuck in the hospital, their nutritional status just dwindles quickly. They don't have access to necessarily the foods and stuff they have at home. They're eating the high-fat grilled menu that most of our hospital cafeterias offer. So some of the things that we can do to encourage them to take care of themselves. I've seen patients' families actually use the stairwells and stuff on the unit. Hang on just a second. There we go. Use the stairwells and stuff for exercise. And I've often been asked why the hospital doesn't allow access to the employee gyms and stuff for those patients that are there for longer than 3 months at a time. And I think that's a valid question. So we have to figure out how we can help these caregivers take for themselves. Are they getting relief at some point, having somebody come up maybe on the weekend so the person can go home for a couple of hours, shower, shave, whatever, and then come back and assume that caregiver role again. So we need to make sure that we're providing care for our caregivers as well. At this point, you need to make sure that you've downloaded that concept map. And the very first one we're going to look at has across the top it says cancer, most common problems, interventions, with a little 2 out beside there. There's also another one, but at this point we're not going to cover that one. So how do we address fatigue? Well, the first thing we need to do is we need to look at some possible interventions. We need to assess the patient. How well do they understand what fatigues them? How well are they doing it? Doing activities in the morning possibly when they feel better. These are the kinds of things that we need to be looking at. We need to cluster their care. So when we go in, we need to go ahead and complete 2 or 3 tasks at one time. We may need to delay other tasks. So it may not be the best time in the world right after chemo treatment to go in and start asking them 20,000 questions. It may be that we need to delay that, let them have a little recovery time, and then attempt to get those questions answered later. One of the drugs that we can administer, with the doctor's order of course, is Epigen, or EPO, you'll hear it called by some. Basically, EPO increases the red blood cell count. You may remember a few years ago in the cycling world, there was some controversy at some of the Tour de France riders because they had tested positive for Epigen, and as a result they had an increased red blood cell count. Basically, that allows them a competitive advantage of being able to hold more oxygen in the circulation. In these patients that have had disruptions in the red blood cells, we may use a drug like Epigen to kind of replace those. One of the other things we can do is, I'm not sure why this keeps coming up. Yeah, there we go. Maybe that won't show up again. One of the other things we can do if our patient's just a little bit distressed is we can provide oxygen as directed. Remember, oxygen is a drug. We need an order for that. But if we see a patient that's just profoundly had an increased work of breathing, just not tolerating things very well, oxygen may be something that we can use. Some also believe that oxygen can help with pain. I'll leave that at that, but know that oxygen is definitely something that's out there that we have at our disposal and that we may need. I am going fairly quickly through these because of file size limitations, both with Blackboard and other outlets out there. So you may have to stop and rewind and go through this a couple of times. What do we want our patients to experience while they're with us? What do we want that outcome to be? We want them to be able to identify their causes of fatigue and explain some methods to decrease fatigue. So again, clustering of care, maybe it's doing simple things like bringing supplies to them as opposed to having them getting up and going and getting the stuff for oral care. Providing a bedside commode not only increases our safety but also decreases the amount of energy we have to expend to take care of our basic needs. As we look at body image disturbance, remember we're working with a middle-aged adult here and young adults, so we're looking at people from their early 20s on up into the 64 years of age. So body image disturbance is going to be a factor that we have to address with this patient population. Some of the interventions that we might look at, one of the big things as a nurse, we need to, even though we have a lot of stuff to do, we need to present to our patients that we have time to actually stop and listen to them. So it's not just this hurried in and out. Every time we need to go in, oh, here, take this med, I've got to go. We need to actually kind of hang around a little bit to allow our patients to express their feelings. Because if we don't know what they're experiencing or what their feelings are, how can we offer any suggestions? We can offer some suggestions for alternative clothing, especially if a patient's losing their hair, a patient that's had mastectomy. There are prosthetics out there that are wearable under their regular clothes. So these are some of the things that we need to be looking at for our patients. Wigs, ball caps, toboggans, that kind of stuff definitely are other items that we want to encourage for our patients. Ms. Crank pointed out during lecture that St. Vincent's has an amazing support group there on campus for their patients that have body image disturbance and can help them. There's actually an entire department that will actually come around and talk to them. Typically in like children's hospitals especially, we have Child Life that will come by and do a lot of this same type stuff for us because regardless of our age, we don't like to be different for the most part. So how do we make them appear more like everybody else? This is going to be extremely important, especially in these 20-year-old populations where they're still trying to establish pair bonds and stuff like that. Think back to Erickson's from your health promotion class and think about how you would resolve that. The outcomes on this one, we want the patient to demonstrate acceptance of the body image. We want them to be able to discuss alternatives to offset those body image issues, and we want them to be aware and be able to verbalize that there are support groups available. Pain, clearly there are many factors that affect pain, both the drugs, the chemo, the radiation, the surgery, the recovery from that. These are all things that we need to be aware of as far as pain. In this group, we don't want to delay treating pain. And in fact, we may go to a pharmacological agent more quickly than we would with other populations perhaps. We don't want the pain to get so far ahead of us that they have intractable pain that we cannot cure. So we really need to be on top of pain, especially in the oncology patient, so that if we get a patient on the call light about pain, we need to possibly get up and go deal with that before we finish a chart check or before we do this, that, or the other. You don't want a patient that with oncology issues to be reporting pain and you decide it's a good time to take a lunch break and not address that pain. We need to assess the pain, be it physical, emotional, or psychological. We need to be aware of what type of pain the patient is experiencing. We need to administer medications as directed. Remember, some of our pain meds, we also have adjuncts to, such as Tylenol and stuff, so we can potentiate the narcotics effect. So we'll want to look at that and see what options we have available to our patient. One of the other things that you really want to do is ask them, what has helped in the past, especially if the patient's got 4 or 5 different pain control methods on their MAR. So you've got these different options that you can choose from. Make sure you actually collaborate with that patient and do some patient-centered care there and say, hey, when it was like this the last time, what worked best? And that may give you